Let's continue on differential diagnosis. Lead poisoning deserves special attention because its mechanism is specific and its laboratory pattern is the reverse of iron deficiency, which makes it a classic examination scenario. Lead specifically denatures the enzymes responsible for heme synthesis, and the word denatures is important here. This is not a reversible inhibition of enzyme activity. Denaturation means the enzyme protein itself is structurally destroyed. When those enzymes are gone, heme cannot be assembled properly, and iron cannot be incorporated. Because iron is not being used, it backs up in the system. Serum iron rises, ferritin rises. But the body is not trying to acquire more iron. It has plenty, it just cannot use it, so TIBC stays normal or actually falls. And because heme synthesis is disrupted, lead poisoning also produces a characteristic blood smear finding called basophilic stippling, where aggregates of ribosomal material appear as granular dots inside red cells. So, to crystallize the entire differential in one place, in true iron deficiency, serum iron is low and TIBC is high, few passengers, many empty seats. In anemia of chronic disease, both serum iron and TIBC are low, few passengers, fewer buses, iron deliberately locked away. In beta thalassemia minor, iron studies are typically normal, but hemoglobin A2 is elevated on electrophoresis. In lead-related sideroblastic anemia, serum iron and ferritin are both elevated while TIBC is normal or reduced. Ring sideroblasts appear on bone marrow examination, and basophilic stippling is seen on the peripheral smear. Understanding this matrix of findings allows correct categorization of any hypochromic microcytic picture without guessing. In summary, iron deficiency anemia in adults is overwhelmingly caused by chronic blood loss, with menorrhagia and gastrointestinal bleeding leading the list. Dietary deficiency matters primarily in infants, especially premature infants and those on cow's milk, and occasionally in the elderly. Increased iron demand during pregnancy and rapid growth in preadolescence rounds out the major causes. Clinically, the presentation spans from simple pallor and fatigue to angina in susceptible individuals, and in severe chronic cases, to koilonychia, glossitis, gastritis, pica, and Plummer-Vinson syndrome. The laboratory shows a hypochromic microcytic picture with low serum iron, elevated TIBC, elevated RDW, and low ferritin, though ferritin must always be interpreted with caution in the presence of inflammation, where it can be falsely normalized. Bone marrow examination for hemosiderin remains the gold standard when doubt exists. And distinguishing iron deficiency from its three main mimics, anemia of chronic disease, beta thalassemia minor, and sideroblastic anemia, including lead poisoning, comes down to reading the iron study pattern, the hemoglobin electrophoresis, and the bone marrow findings together as an integrated picture.